From WXXI News, this is Connections. I'm Evan Dawson. Well, our connection this hour was made with a man named Mike. During an appointment with his doctor, Mike's physician told him he was concerned about Mike's weight. He was close to 300 pounds and was approaching pre-diabetes. Mike's cholesterol levels were also not good, the doctor said. And with all of this in mind, when Mike saw a study for a weight loss drug trial, he decided to enroll. The results, he says, have changed his life. After being on the drug, he's down 30 pounds. But soon after being off the drug, Mike gained the weight back. He tried different programs, different diet programs, and older pill methods, but nothing worked. And after jumping through hoops with his insurance company, he was finally able to get back on the drug from the trial. It was expensive, but between insurance and a coupon, the cost was manageable. That changed when insurance stopped covering the drug altogether. Mike had to stop taking it, and once again, he gained the weight back. After more visits to the doctor and a diagnosis of not processing glucose normally, Mike's doctor prescribed him Ozempic. The medication took him out of the pre-diabetic stage and helped him lose 45 pounds. His doctor then changed his prescription to Mounjaro, and here's what he told our team. Quote, "This truly helped change things in my life. I have dropped overall about 80 pounds, and I'm doing well. I am still losing weight slowly, but my blood work is all great, and I'm not near the highest dose. The doctor is pretty happy and wants to keep me on it for now, and I've been on it for about a year." End quote. Now, he says there are side effects, but he thinks they're manageable. He also said he thinks there's an education and lifestyle component to this conversation. He says just taking the drug without some diet or lifestyle change isn't the way to go, but for some, it may help them get there. And he says he doesn't advocate using this to drop a few pounds for a wedding or because you want to look like one of the actresses or then actors that are twigs. He says it should be balanced. Well, Mike's story is one of millions right now. According to Emily Oster, writing for The Atlantic last week, as of last year, an estimated 15 million adults were taking GLP-1 drugs for weight loss. Some people call them miracle drugs. Others call them a public health concern. In addition to their effectiveness, there are also conversations happening about the cost. Medicaid doesn't cover the drugs, making them inaccessible to many people. A month's worth of Ozempic can run up to $1,000 without insurance. And in her Atlantic piece, Oster argues that if more people could access the drugs, it could reduce downstream healthcare costs in the long run. So this hour, we're talking about the latest with these medications, what they treat, how they work, what we should know about them, who has access to them now, who should be able to have access. And our guests kind of work in a lot of different areas here. We'll go around the table, starting with Dr. Casey Chavone, who is assistant professor in the Department of Surgery, Bariatric GI at the University of Rochester Medical Center. Dr. Chavone, thank you for being with us here.
Thank you for having me.
And next to Dr. Chavone is Molly Ranney, who is lead dietitian for the Bariatric Center at Highland Hospital. Thank you for being here. Across the table is Dr. Zachary Burns, Assistant Professor of Family Medicine at the University of Rochester Medical Center and Associate Director of Moving Medicine Forward. Nice to have you. Thanks for being here.
Nice to be with you.
And Erica Davis is with us, a patient who uses weight loss medication. Erica is a theater professional, an educator, and a mom. Welcome. Thanks for being with us.
Thank you, Evan.
So a lot of different places to go here, and I want to start with just a few questions for the professionals who are probably encountering this a lot more now with how popular these are. And we'll go around the table here. So, Dr. Chavone, what's the change you've seen in maybe the last 2, 3, 5 years on this? How popular are these?
Sure. And these medications are very popular in our office. So not only do I do bariatric surgery, but I do general surgery. And a lot of our general surgery patients who are coming in looking for surgery on other aspects of their body are on the GLP-1s already for weight loss. And you have to have a couple different considerations when you're doing surgery on a patient on these medications, but we're very familiar with it. It's something that we deal with every day, all day.
Okay. Same question for Molly Ranney. How often are you seeing patients, people come in with questions about this?
So we see, obviously, patients for weight loss surgery. And for patients often now, more often, I'm seeing them coming in preoperatively, attempting to lose weight prior to having surgery. And then if they have weight recurrence after surgery, always the opportunity to add another tool to help support them in their lifelong process of overall health. So I think it's something we're definitely seeing the increase of and will continue to see.
What about you, Dr. Burns?
We see a lot of GLP-1s. For those unfamiliar, this is the class of medications that some examples are Ozempic, Wegovy, Mounjaro. So they have proliferated, right? It's part of the reason we're having this conversation right now. The public wants to know what's going on. They're on TV, they're on billboards. I prescribe them. I prescribe them as a primary care physician. And yet I have some concerns. And I come from the lifestyle medicine perspective, and we could get into that if you'd like. But I don't think that GLP-1s will solve our chronic disease problem.
Okay, so before I get Erica's story, let me just hit a couple of other points here. Dr. Burns, do you want to describe a little bit for the audience, not going too technical, but in general, how GLP-1s actually work in regards to the purpose or the goal that some patients have of weight loss?
Sure. They essentially make you less hungry. So they suppress your appetite, sometimes at the cost of feeling queasy for the duration that you're on the medication. Hopefully, in other cases, the symptoms subside and you feel okay. There's a whole range of side effects, some short-term, some longer-term, some reversible, some maybe not. But yeah, hopefully people feel okay on them and they meet their goals of losing weight. But it's essentially an appetite suppressant, and that's why, and the manufacturers are the first ones to admit, when you go off the medication, often the weight rebounds predictably.
Because your appetite comes
right back.
When people are on them, is there a general calorie range that they're in on the day? I mean, I know calories are not a perfect number, and this is not my expertise, but I think what I'm wondering, doctor, is if I came to you and said, okay, I was thinking about, I don't think Ozempic is actually qualified for weight loss. Is that correct? Mounjaro is Ozempic now?
So yeah, Wegovy and Zepbound are the ones that are officially for weight loss.
Okay.
But they're the same compounds as the other ones that are for diabetes.
So I come to you and I say, I'm thinking about GLP-1. I know some people like my friend Mike, and this has gone well for him. But what happens when my appetite's suppressed? How many calories am I getting, or how much food am I actually going to eat? Is there a concern about eating too little? What do you say to that?
Yeah, so it depends on your baseline consumption. The average American is consuming around 3,000 calories a day. It's why today our obesity rate is 42.5% of the American populace has obesity with BMI 30 plus. Severe obesity 40 plus has doubled since 2000. So it comes down to, it's sort of the laws of physics. We're consuming more energy than we're putting out. And so in the first few months when you ramp up on a GLP-1, often you're at a calorie deficit. You could approach 1,000 calories, but then that starts to plateau. So you end up, the appetite suppressant effect at some point, it wears off a little bit and you might consume more calories, and so that deficit decreases, and that's part of the reason that people reach a plateau in the weight loss. You don't lose weight indefinitely, or you wouldn't want to. You'd go down to nothing. But you also, in most cases, if you start with a BMI of 40, you might plateau and your BMI is 35. And that's still in the obese range with a host of risks.
So what are the risks? What are you concerned about with these? As you said, you are prescribing them, right?
I do.
Okay, so what are you concerned about?
So, and this is the way I counsel my patients, because they often come to me. They say, let's talk about GLP-1. I saw an ad for Ozempic. And I say, all right, here we go. We're going to need, I'm going to be late for my next visit, but this is an important conversation. I like to have it. So, the first thing is we want to get a sense of what they've done. What else have they tried? What's their journey, experience physically, emotionally with weight? Because people have a whole relationship with their weight, with any complications, and with food. But you more ask, so we get through that. You more ask about the counseling on, all right, we're starting this thing. What are the risks? The risks include gastrointestinal side effects. So queasiness, nausea, vomiting, diarrhea, bloating. Hopefully those symptoms subside and go away. They don't always, especially when you ramp up to the next dose. People are like, ooh, the first few days after a dose, you can be really uncomfortable. It delays gastric emptying, and so the stomach, there's more contents in there. That's part of the way it suppresses your appetite, and that can lead to gastroparesis, gastro bar stop. And if that becomes irreversible, then basically you stop the GLP-1, and after many months you still have gastroparesis. It's happening more and more, and then the surgeons have to go in and open up your pylorus at the bottom of the stomach and wrench things open. So that
How
food
common
can
is that?
exit. Dr. Schvo- yeah.
Gastroparesis as a side effect of the GLP-1s is relatively common. It being
As in like 10%, 50%, 3%, 1%?
I'm under the impression it's the 10 to 15%.
Okay, that's a lot.
Yeah.
Okay.
It's what also adds to the nausea that a lot of patients experience when they're on the medications. There's some low-level gastroparesis happening typically. It being severe and permanent enough to lead to surgery, relatively uncommon, but it happens.
Okay.
Yeah.
Okay. Continue.
So then you with the weight loss, which does happen, at least at first, you have increased risk of gallstones. Okay, so sometimes you get pain from coming from your gallbladder, and you have to get your gallbladder surgically removed.
We do a lot of gallbladders on patients who are on GLP-1 medications.
So and Dr. Chavone will do this, like with their eyes closed, and I mean, meaning that you do a ton of these, I'm sure, and it's a common procedure, but there's still inherent risks. But anytime there's surgery, right? And then you also, with those gallstones, that could lead to pancreatitis, which is another side effect of these GLP-1 medications. Then you have with that weight loss, unfortunately, not all of it is adipose or fat. So you have lean muscle loss, and different studies, they've showed a range. Some people lose up to 40% of the weight lost is lean muscle. In other studies, it showed more like 15%. But either way, you're losing muscle, and you have to be very proactive to maintain it with your weight-bearing exercise. Another thing is, like, before surgery, right, it increases your risk of aspiration because there's more food in the stomach, and so you have to be careful and stop the medication a week at least before any surgery. It can affect the absorption of different medications like birth control pills, and so you have to be careful there. Meanwhile,
there's actually a black box warning on the medications that you should not be taking them if you are planning to become pregnant.
Okay.
And meanwhile, right, because we don't have any safety data around these medications in pregnancy. So not only do they decrease the efficacy of birth control pills, but you don't want to get pregnant on these. And the list goes on. There's retinopathy, so there are several things. And usually after a thorough and compassionate discussion with a patient, and they actually understand for the first time these risks because they didn't really process it in the fine print on the TV ad, they say, maybe I'll take you up on the referral to the Highland Lifestyle Medicine Department or the Rochester Lifestyle Medicine Institute.
Okay. So there's some of the background. I want to understand Erica's story because everyone's story is their own. Not every story is the same. But there are a lot of stories, I think, like Erica's out there where people are experiencing some. Well, I'm going to let you characterize. Why don't you take us back to what led you on this path?
Sure. Well, I have struggled with my weight my whole life. And meeting me, you might not think that. I think I present as a pretty, kind of a normal weight. But I've fluctuated, I would say the last 20 years, anywhere from about 180 to about 220 is pretty much my norm. Now I'm 5'10", so I carry that pretty well. So even when I'm heavier, and I don't really like to talk numbers, but I figured I'm here, so I'll just throw it all on the table. There's no day like today to just, throw it all out there. So those are the numbers that I pretty much fluctuate at. And at a pretty, I live a healthy lifestyle. I eat healthy. I'm pretty active. But I've always really struggled to keep my weight down. And when I have been, say, under 200 as an adult, I've had to really work actively to keep those numbers where they are. And as I was preparing for today, I put together a little sort of like photo montage. I put together in my phone, I went through, the last 20 years and, the ups and the downs. And I would say in any given year, I would go from that like 180, 190 place to like the 220 place to maybe a little higher at the holidays. And it would go up and down maybe 2 or 3 times throughout the year. And that's about how often and I have a full wardrobe of clothes and I go back and forth, And I think a lot more women go through this than people realize. And you can see throughout the years and in the family pictures, and my children stay the same and the Christmas tree stays the same, but my weight goes up and down. Even to the fact where, you can see certain holidays, certain vacations. Even as I was thinking about, my journey with weight loss, I realized that I was essentially starving myself to meet with my doctor. I would go on a crash diet every time I had a physical coming up because I was so embarrassed to go into my doctor's office and admit that I had gained weight. He was an old family friend. He knew my parents, and the thought of going in and registering as obese on his scale was just mortifying to me. So that's sort of, the background of, and that's been my whole life. That's, I remember this at 14 years old. This has just sort of been how it's been. Now I'm 44, and, there just sort of comes a point where you go, I give up, I surrender, and I always knew that, my whole family is, we all have, we go up, we go down, we like our cookies, but I knew menopause was going to come. I knew my hormones were going to change. I knew at some point I wasn't going to be able to crash diet and get back to looking great. If I cut out carbs for a week, I could fit into that dress to go to a friend's wedding, or look good in a bathing suit on vacation with my kids. And then about a year ago, I sort of said, it's time to balance this out, and I started really buckling down, and I really was eating healthy, and I was exercising. I was doing everything I was supposed to do, but the weight wouldn't come off, and it just wouldn't budge, and it wouldn't budge. And I started to get really disheartened. So all these ads were coming out for all of the, all of the wonderful prescriptions that we're talking about today. And I was really, really against it. And some of my girlfriends had started taking them. They were losing a tremendous amount of weight. I was so jealous, and I was so bitter. And I was sitting there going, not me, not me, not me. I'm not going to do it. So I doubled down on myself. I said, I'm going to lose this much weight by this point in time, and I'm going to look fantastic. And I tried and I tried and I tried, and I didn't. And now some of my other girlfriends have started taking these pills, and now they're looking great, and everybody's looking great. And I'm sitting here and I'm going, I don't look the way that I want to look. I'm trying so hard. I feel terrible about myself. And then finally I just got to the point where I said, you know what? I want to enjoy what I'm doing. I'm working hard. I'm eating healthy. I want to enjoy food. I don't want to feel this guilt all the time. And I really wasn't overindulging. I wasn't doing anything wrong. I just wanted a little bit of help. So one night I just decided to give it a try. It was very difficult for me to come to terms with ordering the pills. And I did order them online. I did not go through my doctor. And that was because when I finally made this decision, it was at 2 a.m. It was in the middle of the night, sitting on my patio crying by myself and having one of those come to Jesus moments where you just go, hey, universe, I give up, and I need to try something different, and I need to try something better for myself. And the hardest part in all of this was the next day, when I felt this tremendous sense of obligation to explain to my teenage daughters that I was going to be taking this journey with these pills, because they're influential. I mean, it's a very delicate situation to be in as a parent, especially with teenage girls at home. And I take that position very seriously. And I didn't want for it to come across as seeming haphazard that I had just jumped into the decision to take these pills. And they were incredibly supportive and we, wonderful. I mean, I couldn't have asked for a better response from them, but it was very, very difficult to get to that point with them. And even when the pills did come in the mail, it still took me 2 weeks to finally decide to start taking them. They sat in my linen closet for 2 weeks while I really thought, again, long and hard about, is this something that I need to do? Can I do this on my own? And finally, I realized I needed some help. And I'm really glad I did, because it really has changed my life.
So we're going to go back to your process in a moment here, because I think some listeners are hearing this going like, wait a second, I thought we're talking about prescriptions, and now you're talking about ordering on the internet, and it's a whole different world. Before we even get there, in general, any side effects for you when you started taking them?
Yes, extreme nausea for about 2 weeks. My joints hurt. I felt very frail. That's almost the best word I can describe it. My bones, my muscles, everything about me, and maybe it was because I was losing weight rather quickly in the beginning. I believe because of the nausea. I was extremely nauseous. It was similar to morning sickness. About a month, it took my body to adjust to all of it. And
Did you think about scrapping it at any point because of the side effects?
Not for a second.
Okay. All right. And once you got past those side effects, any ongoing side effects now?
No, I feel great. After about a month, I feel fantastic.
Okay. How long have you been taking them now?
3.5 months.
3.5 months. What has been the result for you in terms of weight loss?
23.3 pounds
Okay.
so far.
And how do you feel physically?
Excellent.
All right.
Excellent. Sleeping better, moving better, just feeling better in my skin. Feeling like I move better in my body. There was a moment when I had lost a little bit of weight, not a whole lot, maybe 8 pounds, something like that. But I looked in the mirror and it was just something simple like my jawline. Something looked a little different about my face, and it was like I could see myself again. And that moment when I could see myself again was so motivating, and it really turned the corner for me. And it went from being, hey, this was where I was, to this is where I'm going, and that just kept everything. It's the momentum. It's great.
So you said you're an active person.
Very.
Okay. So are you getting enough food to feel like you can do the activity that you want to do?
Oh, sure, absolutely. I mean, it's a lot of work, and it's a lot of meal prep, and it's a lot of planning.
Do you have to make yourself eat? Are you hungry? Do you get hungry?
I don't get nearly as hungry as I used to, and I find that I eat much later in the day than I used to. I do. I get up, I have coffee, I have a lot of water, I drink a lot of lemon water. I probably don't really start eating until about 2 in the afternoon. That's something I have noticed about this, is that I don't get hungry until later in the day. And when I do, I eat about a third as much as I used to. And then my body just says, I'm done, I'm good. And I just stop.
Okay. Are you planning to do this long term now?
I'm planning to do this indefinitely.
Indefinitely. Because, that's kind of the conversation. It's like you start this, and we've heard the stories of what happens if you stop it. So this is, I hate to use the word forever. Nothing is forever, Erica. But for you, in your mind, it's kind of forever?
I would have no problem with that.
Okay.
Yeah.
Right.
I take other medications forever. I take thyroid medicine for forever and blood pressure medicine for forever. Why not this too?
Okay, so back it up here. So you decided at that low moment at 2 a.m. that you were tired of feeling the way you did. You were at that breaking point, and you decided I'm ordering them.
Yep.
Was it hard to find them?
No.
Okay.
Not at all.
And was it legal to find them?
Absolutely.
Yeah, I don't think you're on here talking about breaking the law.
No.
Good. Okay, I'm really glad.
Yeah.
But when it comes to the process you could have taken, why not talk to a doctor first?
Well, frankly, I would have had to pay an exorbitant copay just to get in to see my doctor to have the discussion to order the pills. So I might as well have just done it myself online.
Okay. How has your relationship been like with the medical community about your weight?
Embarrassing.
In what way?
I have, when I have been heavy, when I have been textbook obese, I have never had a doctor look at me and actually tell me that. They always skirt around the topic. They don't want to discuss my weight. They don't want to say, I've had doctors say to me, yeah, you could lose a couple of pounds, but you're a beautiful girl, or you carry it well, or you'll lose it next year. Or I know that, I know you're working on it. Nobody has ever said, hey, for your health, you probably should lose 40 pounds. And I think it would be best for your heart and best for your cholesterol if you, cut out the sweets and cut down on the red meat.
But isn't there a difference between a patient who definitely needs to, for their own health, of maybe addressing it versus some who we carry a few extra pounds? Well, I'm not the doctor here, everybody. I'm not defending your doctors. It sounds to me like you wanted bluntness.
Absolutely.
And you didn't get it.
Absolutely, because the way I see it is my entire life I've carried enough extra weight that I believe in the long term is going to affect my health. And I would have appreciated if maybe somebody had been a little bit more stern with me early on.
Would you have been in a situation where you got a GLP-1 through a physician if you had a better relationship with the medical community before the last few months?
Yes.
You think so?
Yes.
Okay. And I guess you're paying for the drug now.
Yes. Mm-hmm.
Out of pocket.
Yes.
Not covered by anything.
No.
Pretty expensive?
Not nearly as expensive as I thought it would be. I paid $900 for a 6-month supply.
$900 for 6 months. Okay. Can I ask which one?
I use the HERS website.
Okay.
Mm-hmm.
All right. So that's a bit of Erica's story. I want to kind of go back around the table here. And Dr. Burns, I'll start with you. So I want to ask you if you think that, I mean, you haven't been in the room with her doctors, but she hasn't had a good relationship with her medical providers over the years about her weight. And that has not probably been good for her mental health. That hasn't been good for, the kind of trust that happens. Are you worried about that? A disconnect between people who are struggling with issues like weight and the medical community trying to address that appropriately?
Definitely. Yeah, first of all, I just appreciate your courage in being here and opening up about your story, because not a lot of people would do that. So that's great and gives us insights into the patient experience.
Oh, thank you.
So, yes, I am concerned when people can't, they don't feel comfortable coming to us and spilling the beans. And so every visit, every gesture is sort of in the spirit of making someone comfortable so that they can open up. And it's a beautiful part of our work. Now, it's first of all, it's just inherently awkward to broach the subject of weight. And so I think that's why a lot in the medical community, we don't necessarily bring it up. We think we're going to offend somebody, or that it'll disrupt our cherished patient-doctor relationship. There are also, in my residency program, which was not here, there's a massive de-emphasis on weight, and they bring in speakers to tell us that weight made no impact on health.
Healthy at any size, all that.
Right. So this sort of movement, I think it comes from a good place.
But do you think that's wrong?
Yes.
Okay.
I think
that's a direct answer.
I think that it comes from a good place. We larger people have been discouraged by the healthcare system. It's really terrible. We need to make them feel welcome and comfortable participating in healthcare, and also just societally, we do not want anyone to feel ashamed. That said, we have to be real in the exam room about the risks associated with having extra weight. And I found, echoing Erica's sentiment, my patients typically enjoy when I'm direct. They don't want you to dance around stuff. So yeah, they want to talk about it. And what I try to do is ask permission. I say, would it be all right if we talk about your weight? And then they can say no, and I'll respect that. And if they say yes, it's like they've kind of given me, the green light to get into it. And almost everybody says yes. And then we can talk, and they're relieved to be having that conversation, because there's a lot of angst about it at home. It can be really troubling to be obese, to struggle with your relationship with food, and so you want the opportunity to make a plan with your doctor.
So let's go around the table here. Molly, Randy, what do you make of some of Erica's story?
I, again, am very appreciative for you sharing what you've shared, and I hear it all the time, not only in the work that I do at Highland, but just in conversations with people that, I'm friends with or family. And I think it's unfortunate that we, again, look at people based on weight and size. And I know at our center, we really want people to come with us and understand this is a collaborative effort. We are going to help you move through a process of improving your health, whether that is weight loss medication, whether that is having surgery that will get you farther down the road as far as overall health. We're in the process of working to have a medical bariatrician. We've been approved for the position. So we are going to be expanding our offerings to people so that we have people that will come to us and really have someone, that's part of their team to help them.
Okay. And Dr. Chavone, you want to weigh in on the story as well?
Yeah, I think, Erica, unfortunately, it's a story that we hear a lot of, like Molly mentioned, and a lot of it revolves around stigma, right? Patients feel that stigma because there's a lot of shame when you've struggled with your weight, from societal pressures, your own internal pressures. There's a lot of stigma coming from providers, right? Many times we've documented that even providers who work with those who suffer from obesity treat those with obesity slightly different than those who don't suffer from obesity. Whether it's internalized stigma is, plenty of research has gone into this. So there's stigma from both sides, and people are in my office to talk about their weight, and not everybody wants to talk about their weight, right? It's still hard to kind of broach that subject with all patients. And the only thing we can do is sort of reduce that stigma so that people feel comfortable coming to us, right? Because as you described, you even felt some sort of stigma even reaching out for the medications, right? There's a lot of this conversation where, oh, it's taking the easy way out, which is so inaccurate.
Oh yeah, definitely. It was. I was so embarrassed at the thought of even going, and it was like I would have wanted to wear a disguise to go into the doctors to ask for the medication. I mean,
exactly.
Yeah, absolutely.
And the things that we're doing in our office, and Molly can attest to this, is we use inclusive language and we make the environment comfortable for people to be able to open up and talk about all of the good and the bad and the ugly with us.
So, and let me also just say observationally, I don't have any of your expertise. The only thing that I do is talk to people and observe how people communicate and form beliefs and share information with each other. And one of the things that has been interesting to me over the last, well, I don't know when the Ozempics really hit the scene. I don't know if it's 5 years ago, that's probably longer, but they've really taken off in the last few years. And I've had a lot of physicians privately, medical professionals privately over the years, say to me, I can't say this on the air, but I'm not all that comfortable with the healthy at any size movement, with the idea that, every weight, every size is equally healthy and okay. And so when you say, Dr. Chavone, that it can be really hard to talk about this subject, like my response is twofold. It's like, yes. And then it's like, not as hard. It shouldn't be. To the point that Dr. Burns was making, most of the patients you ask when you say, is it okay if we talk about your weight? You said most of them say yes.
Correct.
Okay, maybe more than you would have expected, back in residency. It's like people will say yes. And I'm kind of with Erica. It's like, no, I need you to talk about my weight at that moment. Like, I want you to talk, this is not me out at a restaurant. Like, this is me with the medical. I want you to talk about this. I need you to tell me.
I would have welcomed it at any point in time. And frankly, it's probably in the top 5 of my, most sensitive topics that I would want to talk to. Number 1, I would want to connect with my doctor on it. And number 2, it's going to help me with my mental health. It's going to help me with my self-care. You know what I mean? So it would benefit me tremendously to talk to my doctor about that.
Yeah. So go ahead, Dr. Burns.
So because as a medical community, we tend not to talk about it because we're squeamish or whatever, or we've been told not to talk about it, or we have this perception that patients don't care. They haven't noticed that their BMI is 45. Then what happens is the only option for weight loss that patients seem to be aware of is like going on a GLP-1 because they're inundated by the advertising. In the year 2024, the 3 drugs, Wegovy, Zepbound, and Ozempic, there were $500 million of advertising just in 1 year for 3 medications. So you wonder, like, well, if these things are so good, why do they have to advertise so much? Maybe the doctors would just recommend them on their own. No, not necessarily, because there's some issues and there's some alternatives. So they rely on advertising for people, for the public to be really fixated on this and feel like they need to be on one. And so, there is an alternative. I just want to make sure I mention this. Lifestyle medicine talks about the basics. It's not controversial stuff. Eat your fruits and veggies, take some walks, reduce stress, sleep adequately, right? And it sounds silly, but it's like this is actually the center of human health. It's lifestyle medicine, and there's a huge international movement that is getting us back to that. The American College of Lifestyle Medicine is kind of the hub. And here in Rochester, we have the lifestyle medicine department at Highland. So they sit down with people, 90-minute intake, they make a comprehensive plan around these different pillars: diet, physical activity, et cetera. And then in the community, the Rochester Lifestyle Medicine Institute, they do a 2-week jumpstart. And what do these organizations have in common that I mentioned? It's evidence-based nutrition. And so it comes down to whole plant foods. Sometimes we call it a whole food plant-based. We just have mountains of evidence that it can prevent and also reverse the vast majority of human chronic disease, including stuff that we didn't think could be reversed. So helping people stay in remission from prostate cancer or reverse their advanced coronary artery disease that leads to heart attacks, or reversing type 2 diabetes. That's another question I ask my patients who come to me from someone else and they have type 2. Or, I check their sugar level and it's a new diagnosis of type 2 diabetes. I ask sort of for my own mental charting. I say, has anyone ever told you that type 2 diabetes is reversible? Invariably, they say no. No one's ever told them that. But even the American Diabetes Association has criteria for remission. So if you go back to a normal sugar level for 3 months off medication, you don't have type 2 diabetes anymore. You're in clinical remission. And everyone deserves to have that option presented to them. And most people who are granted that option, they say, yeah, tell me how this works.
Okay, but before we were really late for a break. They're going to start yelling at me in a moment, and I've got a lot of listener feedback to share. But just briefly, Dr. Burns, I take what you're saying on all of those points. But then the logical question I have then is, why are you prescribing anybody with GLP-1s after, the great presentation you just made for whole food plant-based?
Sure. Yeah. Thanks for giving me that chance, because I realize it could be confusing. So I prescribe GLP-1s because I think they're appropriate in some cases for some people, and I don't want to be a gatekeeper. And so I give them the options. I make sure that they understand the lifestyle approach with adequate, I make sure they understand all the side effects, not just paying lip service to a couple of them. We talk thoroughly about the risk, benefits, and alternatives, which you're supposed to do before making any medical decision. And at that point, if they'd like to proceed with the GLP-1 and they meet criteria, then we roll with it, and we consider it harm reduction. So I have plenty of people in that situation. I think it can be appropriate as an interim solution while we're aggressively working on lifestyle changes to both mitigate side effects and keep them in a healthy place, when often their employer-based health insurance or whoever's covering the GLP-1 changes their mind, and they show up at the pharmacy counter and they feel like they're back at square one. So we got to build sustainable lifestyle habits to keep the weight off.
So does that convince you you're going to get rid of the GLP-1s and go whole food plant-based?
Nope. Maybe after the break I can provide the counter argument.
Okay, all right. So let's do this. Let's get our only break. We're very late here. We're talking to Dr. Zachary Burns, who is a professor of family medicine at the University of Rochester Medical Center and associate director of Moving Medicine Forward. Next to Dr. Burns is Erica Davis, who is sharing her personal story. And across the table, Dr. Casey Chavone, who's a professor in the Department of Surgery, Bariatric GI at the University of Rochester Medical Center, and Molly Ranney, who is lead dietitian for the Bariatric Center at Highland Hospital. We'll come right back. More on Connections in a moment.
Supporting your favorite programs on WXXI TV and radio is just a click away when you go public at WXXI.org. It's a convenient and secure way of supporting an important community resource. WXXI.org. Go public and pledge your support today.
This is Connections. I'm Evan Dawson. Okay, Dr. Chavone, the floor is yours here. Go ahead.
Thank you. So lifestyle changes, diet and exercise are obviously one of the pillars of weight management that we offer in our clinic. However, we have decades of research that show that just lifestyle management isn't enough to continue to lose weight, right? If that was it, then I wouldn't have a job, and I very much do. So I think one of the really interesting examples of that is the show The Biggest Loser, which I think all of us are familiar with. It was on NBC. It was a competition show basically with diet and exercise, seeing who could lose the most amount of weight.
But it was starvation.
And
that was extreme.
Yes, it was extreme diet and exercise. So there was one really amazing paper that followed a season of those contestants for 16 years after the show. And they found that all of them regained all of their weight despite following the strict diet and exercise plan that they had developed on the show. So even though they were doing everything quote unquote right, they still regained all of that weight. And when they went and they did some evaluations of their BMI and their fat percentage and their metabolic rate, they found that their metabolic rate actually had decreased throughout time with that strict diet and exercise, which meant it was harder for them every year to continue to lose weight and to continue to maintain that weight loss. So we know that just diet and exercise isn't enough. We know that obesity is a hormonal and a genetic disease, not just a disease of lack of willpower, which I think is a lot of where that stigma comes from, right? This is not just lazy eating.
Okay. Is that fair, by the way, Dr. Burns? Do you agree with that?
I would say that diet and lifestyle can absolutely be enough. We have not, as a medical community, we've not adequately educated the public on these themes. There's so much to it. It involves, a ton of follow-up and support, and just public health. We have not invested enough in lifestyle medicine, and we really need to, given the health issues that we're facing.
So you're saying with the bigger sample size, more study, you think it would bear out that what you're describing would be sufficient?
Yeah, there are plenty of lifestyle studies that do show.
But what about genetic markers for obesity? What about some of what your colleague across the table is talking about?
Yeah, obesity is multifactorial. There are some genetic predispositions for all of these chronic diseases. It's just that the environment plays an infinitely larger role in this issue. And the elephant in the room is we're in an obesogenic environment. So we have billboards for Chick-fil-A. We have all this junk everywhere, and fast food everywhere. In between the ads you might see, it might be a consecutive advertisement for Taco Bell, and then Ozempic, and then McDonald's, and then Mounjaro. These are it's big money. So that's what we have. That's like our exposure, and we need to address that. Just like in the 90s we did with tobacco, the public health community said this is actually enough. The suffering and the actual costs inflicted on the healthcare system are enough. We got to do something about this.
So let me ask your colleagues if they want to respond to. Go ahead. Yeah, if you both want to jump in here.
Well, one of the things that I think is a challenge for everyone out there is that we are bombarded by nutritional opinions left and right. Eat this, don't eat that, eliminate this food group. And I know one of the things that we focus in on our center is eating whole foods, like moving away from processed foods, getting in adequate protein, getting in enough fiber, moving your body more. We are up against a very seductive food environment, and it is very difficult, I think, for people to follow through on the foundation of what we're discussing at the table. And some people don't have, affordability is a piece of that puzzle. Accessibility is a piece of that puzzle. So I know in our center, when I'm working with people, I try to distill down, let's keep it simple. Let's work together with what you're consuming. Let's make these changes in a process, regardless of what way you go, whether you have surgery or you take a weight loss medication. It is a win, right? Nutrition, movement is going to be a win for everyone. But I think we have a lot working against us and our patients as far as their ability to follow through with just moving more and adjusting what they're eating.
Okay, anything you want to add, Dr. Chabon?
I would agree that diet and exercise lifestyle is critically important. And I like to at least tell our patients that it's one tool that we have in our toolkit. It's not the only tool.
Let me also, before I get some feedback here from the audience, Excella sent us a note this morning just wanting to say that there was some confusion in September centered around whether or not we are covering GLP-1s in 2026. Excella says GLP-1s are used to treat certain medical conditions like diabetes, and they are still covered. 3 GLP-1s for weight loss, Wegovy, Zepbound, and Saxenda, can still be covered through an exception request from the member's provider as long as the prescriber can verify that the member meets our coverage criteria. And so it goes on to say, our coverage guidelines ensure that members who would benefit the most can access these drugs while receiving vital nutrition and fitness education as well as support from their provider. And the ongoing debate at the federal level is, how much should GLP-1s be covered? Emily Oster writes this piece in The Atlantic last week basically saying it is going to be expensive and the federal government should cover them because of the downstream effects, because of the way that they will reduce healthcare costs outside of the immediate need for GLP-1s.
There's a statistic.
You're nodding over there. You agree with that?
Agree. There is a statistic that persons who suffer from obesity will experience a 34% increase in their cost of medical care. So obesity itself is expensive. Treating obesity is cheaper than dealing with the repercussions and the ramifications of obesity.
So you agree that the federal government should be willing to put some money forth up front, saying that the downstream effects are going to be worth it?
As somebody who treats obesity, yes, I think that the GLP-1s are another tool that we have in our toolkit for the right person.
Dr. Burns, should the federal government be covering GLP-1s? Should Medicaid cover it?
I actually think so, because I don't want people to not have access to GLP-1s just because they have a lesser insurance policy. And at the same time, if we're going to do that, which will increase national health expenditures by so much, in Emily Oster's article, it's a little speculative. We don't know exactly how much it'll save and if there'll be some savings from chronic disease complications, maybe. But either way, it's going to be an astronomical increase in our national health spending, which is already more than any other country in the world spends by far on healthcare. We're not doing too great, right, from the chronic disease perspective. And so if we're going to cover more GLP-1s, we should aggressively invest at the same time in public health, pull the junk food advertising from TV, pull the pharma advertising, to be honest, because it's just inappropriate. There are only 2 countries in the world that allow direct-to-consumer advertising of drugs. And let's educate the next generation of doctors to bring nutrition and lifestyle into the exam room instead of dancing around it or just not really having learned, so they don't feel comfortable providing that counseling. So that's in my nonprofit Moving Medicine Forward, that's exactly what we do. We reach med students and residents around the country to make sure that, because it's not in their curriculum, just learning about food as medicine. So we get it in and they find it really inspiring.
Okay, a little bit more feedback here. Some questions on addiction, and I think it was Molly Ranney, lead dietitian for the Bariatric Center at Highland Hospital. You might want to jump in on this point. People are asking whether GLP-1s also have an effect outside of just obesity. What would you want them to know?
In my experience, the patients that are taking them have said to me, first and foremost, the food noise disappears. And I don't know that people who haven't had the experience of dealing with the food noise to how impactful that is on their life. So when people say to me, you know what, I don't have this constant chitter chatter of what I should be eating or the struggle about maybe not eating something, and how freeing that is for patients, it allows them to then execute the meal plan that we're discussing and doing more movement. So some of the other side effects that I've seen, or what patients have just told me, is alcohol consumption goes down. They're not shopping as much. Maybe, people who like to gamble aren't gambling as much. So there's an overall impact on the addictive behavior, and we have to remember that food is highly addictive.
And briefly, alcohol consumption for you, can I ask?
Yeah, absolutely. Once I started taking the pills, I noticed a tremendous decrease in my desire to drink alcohol at all. I really went from being like somebody who would drink maybe a glass or 2 of wine a day to not craving it at all and not even really enjoying it anymore. So it was great because there was just less calories I was consuming and more weight that was coming off. So it was a win-win.
All right, real quick here, keep going with your comments. Greg wants to know, he heard gallbladder issues are common for people who use new weight loss meds. Is that true? Gallbladder issues.
Very true. So any sort of rapid weight loss is going to increase the amount of gallstones that you have, or have you developed them for the first time. It can lead to problems where you're just having right upper quadrant pain to, like Dr. Burns mentioned, having issues downstream where you're developing pancreatitis. For that, we typically recommend having your gallbladder taken out, which is another surgery.
Jamie writes in to say, it was not difficult for me to access the medication at all. My endocrinologist prescribed it. They were looking to get my glucose levels down to a more steady range and had first started me on Ozempic. There was not much of a change, so I switched to Mounjaro. Since I see my endocrinologist every 3 months, they noticed my A1C dropping and my glucose readings were in the normal range. Over the course of a year, we've increased my dosage from 0.25 to 1.25, and I have lost 57 pounds. So it says, so far, so good for Jamie. I mean, a lot of people are sharing stories like that, and we appreciate hearing from listeners. So we're just going to be brief here. If I can ask you to do it in 30 seconds or less, what do you want to leave with the audience? Leave in today's conversation, Doctor.
Sure. We need to address obesity, diabetes, and the other chronic diseases, which account for 90% of our national health expenditures. And we need to really address this. And we got to do it by the root cause. So why are we this sick? It's only been in the last 40 years or so that the rates of these diseases have proliferated. So is that because we suddenly developed a different genome? No, it's because the food environment has become extraordinarily toxic. So let's address that from the public health level, and then on the individual level, do tons of lifestyle counseling. And in rare cases, if and when appropriate, we do a GLP-1 because it can be the lesser evil, and it can certainly make a difference for people, but only if we're also working on lifestyle change simultaneously.
Molly Ranney, final thoughts. Keep it tight.
I would say ditto to everything you just said, that I feel like we need to do a better job of educating our public on what it means to eat healthy and to move more. And then we have these other tools that we can incorporate.
Dr. Chabot?
I would say obesity is a chronic disease that affects multiple organ systems in your body. We have a lot of tools available to treat it. I would say that the only tool that can permanently alter your hormonal cascade and allow for continued weight loss is surgery. GLP-1s do it temporarily while you're on them.
Okay, and Erica?
Okay.
Continued good luck to you. Go ahead. Final thoughts.
Just that it's okay to let yourself be happy, and you don't have to be stuck in the situation that you are in. And go ahead and give it a try.
Put it on your calendar 1 year from today. We'll come back and talk to you then. See how you doing.
Sounds good.
You're welcome back. In fact, you're all welcome back. Really, I appreciate all of your expertise. Thank you for sharing it with us, and thanks for being here. Our thanks to Dr. Zachary Burns, Dr. Casey Chavone, Molly Ranney from the Bariatric Center at Highland Hospital, and Erica, thank you for sharing your story. Thanks to everybody here.
Thank you.
Thank you.
More connections coming up.
This program is a production of WXXI Public Radio. The views expressed do not necessarily represent those of this station, its staff, management, or underwriters. The broadcast is meant for the private use of our audience. Any rebroadcast or use in another medium without expressed written consent of WXXI is strictly prohibited. Connections with Evan Dawson is available as a podcast. Just click on the Connections link at WXXInews.org.